Good evening, everybody, and thank you for joining us this evening for our TIF Talk. I'm Andrea Millers with Endogastric Solutions, and today we have our special guest, Dr. Eckhert. Dr. Eckhert is a fellowship-trained general surgeon specializing in advanced laparoscopic and robotic surgery. He currently serves as director of the Heartburn Center, director of robotics, and chairman of surgery at Mercy Hospital of Buffalo. He is also the co-chair of robotics for the Catholic Health System. Dr. Eckhert completed his general surgery residency and a fellowship in advanced laparoscopic and robotic surgery at Albany Medical Center. He earned his medical degree from Memorial University of Newfoundland Medical School and his undergraduate degree from the University of Dayton. Dr. Eckhert is a board certified by the American Board of Surgery and a fellow of the American College of Surgeons. Welcome and thank you for being here today, Dr. Eckhert.
Thank you for having me.
So we're really excited to talk about GERD today, obviously, and the TIF procedure. So we're going to go ahead and start. Oh, one thing I did want to mention is, as you all know, this is a live event. So at any time, if you have any questions, please feel free to type them in the comment section, and we will do our best to answer all of your questions this evening. So before we go ahead, let's go ahead and Dr. Eckhert, can you talk a little bit more or talk about what is GERD and acid reflux, and what are the symptoms that patients could potentially be feeling if they were suffering from GERD?
So when we talk about GERD or gastroesophageal reflux disease, it's what a lot of people consider heartburn. Heartburn is actually very common that a lot of people get. It causes that kind of chest burning or pain, or belching, or getting sour taste or acid in your mouth. Again, as I said, heartburn is very common. We refer to it as GERD when it occurs 2 to 3 times a week in an individual. And that's when it becomes more of a medical issue that should be looked at. Besides the burning in the chest, you can have indigestion or stomach, or you can get a sore throat or regurgitation or throwing up of food at nighttime, especially.
Right. Well, I'm glad you, as a lot of people always ask, at what point do I need to seek additional help besides just, the regular lifestyle modifications and or, taking over the counter Tums or PPI. So when you had mentioned that when it happens, more than, 2 to 3 times a week, then you consider that GERD. Can you talk a little bit more about what, I did mention a little bit about lifestyle modifications, but elaborate a little bit more. What could patients do, initially if they start feeling their symptoms more often? What are the types of things that they can do, like I had mentioned?
Well, I think the most important part is when people get heartburn or GERD or reflux, is to really find those trigger foods that do that. And most of the time, people know when that may happen. If people are trying to stay away from the foods that cause it, like spicy foods, fatty foods, alcohol, and they're still getting a reflux, and other things to start with, in general, would be weight loss, if that is a contributing factor. Eating smaller, more frequent meals, not overeating, not eating 2 or 3 hours before bedtime. And then one thing to do at nighttime if you're getting regurgitation is to elevate the head of your bed 4 to 6 inches. So I think it's finding those trigger foods that are the best, because most people have something they know will cause them heartburn.
Right. So food aversions, if you will, from those trigger foods, and then making those modifications. What, can you talk a little bit about medications or medical therapy for the treatment of acid reflux or GERD, and what types of medications are out there? What are the kind of like stages of medications that people take generally for acid reflux?
So after lifestyle medication like we talked about, then mostly would start taking things like antacids like Tums or Rolaids to help with their symptoms at the time they occur. Once if people are having more routine heartburn or reflux, then taking things like an H2 blocker or Pepsid is something that can be frequently taken on a daily basis. And then obviously over the last decade, PPIs or proton pump inhibitors, Prilosec over the counter, or other things like Nexium or omeprazole are prescribed medicine that people can take daily, either once or twice a day. That is kind of like the second line of treatment after lifestyle change.
Okay. And, patients are starting more and more to get a little more versed or educated on, medications and medical therapy and potentially the side effects of long-term use of these types of medications, PPIs, whatnot. Can you talk a little bit more about that and what is it really serious? Do they need to worry about that? Yeah.
So yeah, over PPIs or the proton pump inhibitors people were using for the last decade and getting great results. But as we're using more of them, there are some warnings that taking long-term PPIs can cause. Typically, the more common ones that we talked about are increased risk of fractures or decreased bone density, dementia, some chronic kidney disease. It has also been linked to increased infection of the colon with C. diff. So where these are warnings, it's that long-term use that we're starting to see more of that type of thing. So absolutely, patients are looking to get off medications that are even when they're actually helping relieve their symptoms.
Yeah. Yeah. Okay. So can you talk a little bit more about, what are the treatment options today, aside from the lifestyle modifications, the medical therapy, what are the treatment options that are available today to treat GERD, if you will?
So when we start looking at after medical treatment, you're looking at surgical options. What reflux is actually it's a mechanical problem. There's an ineffective valve or system between the esophagus and stomach that allows fluid to go up into the esophagus. Even with medical treatment, that doesn't prevent reflux. It just prevents the acid, which is what's causing the symptoms. So you're still refluxing. So the surgical treatments that are available all kind of work around trying to recreate that valve to prevent fluid from going up, but also allowing somebody to be able to eat and then vent, meaning belch or vomit if necessary. The more traditional one was the Nissen fundoplication, which was taking the stomach and wrapping around the esophagus 360 degrees. That has kind of lost favor because of the side effects of inability to belch, vomit, as well as a lot of people had trouble eating afterwards. So that was used for people that had just severe reflux that was unable to be managed by anything. As you were talking about, the TIF is actually a procedure that has allowed to recreate the valve, but has virtually long-term no side effects from the inability to belch or vomit and or have dysphagia. Because it has such a safe profile and it works so well, patients that not only can't be treated medically are actually looking to have the procedure done so they can be off their medications and still have basically a reflux-free life.
So are there so there's a Nissen and then there's the TIF procedure. Now I understand we chatted a little bit earlier that you've been doing the TIF procedure for quite a while, or you did it way back in 2008, is that correct? And
Yes.
started doing it now with the new new device, the TIF 2.0 device, if you will.
Yes.
And what's the difference from then to now as far as like patient outcomes and also ease of use for you? Is it that much better for you?
Yeah, I think that the new technologies made it much easier to do, more efficient, as well as more reproducible. So we're able to have get that 85% of patients off medications, where the older device, I thought the reproducibility was a little harder to do, but now we can do the same case over and over again. The other thing I've added to my practice is that, and we can talk about this more, but hiatal hernias. So a patient that has a hiatal hernia, really with any reflux operation, that needs to be repaired first.
Yeah.
And I repair a lot of hiatal hernias and then do the TIF at the same time. So if I restore everybody's anatomy back to normal, again, it makes the fundoplication of the TIF much more reproducible. So our outcomes are better.
Can you explain or elaborate on what a hiatal hernia is and how that works and relates to the esophagus, yeah.
So in this setting, a hiatal hernia in general is when the stomach that's supposed to be in our abdomen will move up through the diaphragm and into the chest. There's actually a wide variety of different types of hiatal hernias. When dealing with reflux, it's just typically the valve or this area slides up into the chest, and then it doesn't function correctly. So that will can lead to reflux or actually be involved with it. So that's what we need to bring back to normal prior to doing anything with that GE junction or that valve area.
Right. Perfect. Thank you. We have a couple of questions. I'm going to try to get through some of them before we go on. We've got a question. Sorry, I got to look at them real quick. From Tara, she's asking, can GERD affect a person's sleep apnea? My husband has been diagnosed with GERD, and I've noticed his sleep apnea is getting worse.
It absolutely can. So reflux can have a lot of issues at night. So laying flat, getting that reflux, even if it's bile, just fluid or acid. So you may not have heartburn, but it can definitely cause choking, and it actually can cause apnea and or worsen it if you already have it. So again, just correcting the acid part of it doesn't stop the fluid from coming up, which is going to cause sleep disturbance in somebody with apnea or not, but that's a very common issue.
Okay, thank you. Another question from Mike is asking, should I be worried about taking my Nexium during COVID?
It's a pretty complicated question, but there has been some discussion or literature out there that PPIs have caused an increase in the severity of the infection. That's all I can really say to that. So there has been some discussion about that.
Okay, thank you. And then we have a question, do GERD and hiatal hernias often occur in the same patients? So I guess.
Yes, I think that and there's actually a little bit debate of which comes first, because reflux can cause a hernia by changing the lining of the esophagus. But I'd say the vast majority, 90 to 95% of patients that I look at to do anti-reflux surgery do have some type of hernia, whether it's small, medium, or large.
Okay. So let's go ahead and talk a little bit more about how the TIF procedure works. Do you mind explaining how the TIF procedure works?
Yeah, so one of the advantages of TIF procedure, which is transoral incisionless fundoplication, is that in a patient with a small hernia or no hernia, it's done all through endoscopic or endoluminal therapy. So it's done without any incisions to the abdomen. So essentially you go down through the esophagus into the stomach, just as if you're having an endoscopy. There's a device that is used to basically bring the esophagus and the stomach together, creating a valve that's ideally like 3 centimeters in length and has about a 270-degree fundoplication or twisting of that area. And the device allows you to set that area where you want, and then it places fasteners through the esophagus and stomach, holding them together. I think that's one of the huge advantages of this. There are multiple fasteners, up to 20 that you can put in there, and it causes a fusion of the esophagus and stomach, which I think is going to give us that long-term, hopefully potentially lifelong correction.
Perfect. Wonderful. And before we go on to more questions, can you talk a little bit about the diagnostic workup? What types of tests do patients have to do in order to determine whether or not they are a candidate for a surgical or the TIF procedure?
Actually, so a lot of it's done, at least in my practice, a lot of it's done by history, getting a good idea that that's what we're dealing with. Everybody does need an endoscopy or an EGD, where that's where somebody's sedated and you put the scope into the esophagus and stomach. One, to evaluate if there's any damage from reflux, esophagitis or inflammation, or changes in the esophagus. And then ideally to look to see if there's any type of hernia to help determine what type of repair we need to do for that, or if we can just do a TIF. So everybody definitely gets an endoscopy.
Okay.
I personally will have most patients do an upper GI where they swallow barium to look at the anatomy of the esophagus and stomach and make sure there's no other any other pathology that may need to be worked up or evaluated. And then depending on the patient, I do esophageal manometry, where a catheter is placed into the esophagus. You essentially drink like 12 shots of salt water, and it makes sure that the esophagus functions correctly. That is patient driven, depending on their symptoms or if I have concerns for anything else.
Okay. Perfect. Thank you. Let's answer a couple more questions. Kathleen is asking, how would you decide if a patient is more suited to TIF or the LINX procedure?
So it's a great question. I actually do both. So I do the LINX procedure, which briefly is where, again, fixing the hernia and then placing magnetic beads around the esophagus. So again, doing both, I really try to tailor for the individual. I am leaning more toward the TIF currently because it does not have a permanent device placed in the esophagus, as well as there's less risk of dysphagia. But for some patients, the LINX is excellent. It's just a matter of kind of teasing that out with history and what the expectations are.
Sure. Perfect. Thank you. And Shane is asking, is GERD best treated early or once it progresses to a certain point?
I think once people get GERD, I think they should be evaluated. Some of it is symptom driven by the patient. So doing it early, where I see a lot of patients wish they had done it years prior because they feel so much better once it's done. And you absolutely want to have treatment before it progresses into something where there's some permanent damage, either to the esophagus leading to Barrett's esophagus or Barrett's disease, which can lead to esophageal cancer, as well as there are a lot of symptoms that we can talk about when we talked about the silent symptoms, where people will have problems in their throat and their lungs, that it is better to do something early before there's any permanent damage.
Yeah, that's a good point. And the next question I was going to ask, Matthew asked, my wife was diagnosed with atypical GERD. Is that treatable? So maybe you could talk a little bit about it, the typical kind of versus the atypical symptoms of GERD or acid reflux or LPR even maybe.
Yeah, so when we talk about, so the typical symptoms we talked about earlier, having, heartburn, regurgitation, chest pain. Atypical symptoms, which we're seeing a lot more of because we're realizing that reflux can cause a lot of these, is atypical chest pain or chest pain that's been worked up for cardiac reasons and the heart is fine. And then as well as it can cause swelling or irritation of the voice box or your larynx, causing hoarseness. It can cause irritation to the throat or the pharynx, which can lead to a chronic cough, or people that are constantly trying to clear their throat, as well as it can cause asthma or problems with breathing. So patients that have those symptoms are typically worked up by another type of physician or ears, nose, and throat or pulmonologist. But we're finding that reflux is causing a lot of that. So that's surgical management, because we need to actually stop the fluid from going up, regardless if it's bile, acid, or just normal fluid in the stomach. So that's when an anti-reflux surgery can be life-changing.
Perfect. Let's talk a little bit about, the day of the procedure, or what could potential patients expect during the procedure. Are they there overnight? Do they get, is it an outpatient procedure? Maybe talk a little bit about that with your practice.
So as far as overnight, so the vast majority of my patients do stay overnight. I do have a select few that I will send home that day, and that's sometimes patient preference, as well as if they have any other comorbidities or other health problems. But I think the patients that we do in the morning, we're being a little more, I'm not sure, aggressive or lenient on letting patients go home, especially if they have a support system there. When they come in the hospital, these procedures are done under general anesthesia. So my procedures are done in an operating room, or they can be done in an endoscopy suite. But the patients are put to sleep for that under general anesthesia. Typically, it takes about 40 minutes to do a straight TIF. It takes about an hour and a half if I'm going to fix a hernia as well. And then, the recovery there, people will be in the hospital for, anywhere from 4 to 6 hours if they are going to go home, to make sure that they can tolerate liquids, there's no nausea, and their pain's well controlled.
And as far as, kind of post-op protocols, diet, when they can go back to work, exercise, all that kind of stuff, what's your protocol generally for these patients that are having the procedure?
Well, I guess I'll start with, as I said, most of patients I will fix hernias. I'm pretty aggressive about even fixing small ones, because I think it gets us better anatomy and a better procedure with the TIFs, so long-term outcomes. So I talk about both the surgical recovery, which is about 2 or 3 days of some discomfort because of the incisions, sometimes some shoulder pain because of the gas we put in, and usually within a week, everybody's up and around, driving, going back to light duty work, walking, stairs. And then there's about a 4-week recovery back to strenuous activity or heavy lifting because of the hernia repair.
Okay.
Usually it's about a full recovery from surgery after about a month. When I talk about the reflux procedure, the TIF procedure, there is also the recovery from when one can get back to normal eating. So that is about 6 weeks. Patients go home on a liquid diet that I usually say it's a pourable diet. Anything they can pour, they can have, as long as it's not carbonated alcohol or have caffeine in the first week or two. And then we start advancing their diet with a soft kind of mushy diet. And then over 6 weeks, we'll get back to a regular diet, depending on how they're doing. And I work with them through the 6 weeks to help get them through that. That first 2 weeks can be a little, little rough.
Little rough. I was going to ask you that. How do your patients generally, when I look at all of the Facebook groups and they talk about, any anti-reflux procedure, it's always, what can I eat after I have the procedure? But I've been told it's best when you prepare, before, and you have everything kind of ready with protein shakes and whatnot. Is there any recommendations or advice that you have for those patients?
I think the one thing I try to do is try to explain why we're doing it. So they need to understand that there's a reason. And it's because we want that serosal fusion to happen. We don't want anything to get stuck, which would cause retching or vomiting, which can disrupt the repair, and that there's swelling. So we have to give the time for the swelling to go down and for this to heal. So I think if people understand why they're doing it and they know it's to get a good long-term outcome, they're a little easier. And I definitely think preparing them so they don't go shopping when you're hungry type of thing. So get the food you need and the drinks you need at home.
Yeah, perfect. I'm going to go ahead and get through some of these questions. We got a lot more questions asked. Let's see. Kathleen's asking, how many TIF procedures have you done to date?
So I think probably done about 40 between back when I was doing originally. I've done, I think, roughly around 20 within the last year. So I've been really kind of building my TIF practice. And actually, probably the main reason of that is that I'm fixing hernias at the same time, and the outcomes have been so good that that's kind of what I'm starting to offer more.
Wonderful. So your patients are really responding well to the hernia and TIF procedure combined, is what you're saying.
Definitely with that. And if somebody actually does not have a hernia that and I do the endoscopy personally, then they're doing just as well. But yeah, they're reflux free right away. They're off medications usually in that first month. And
yeah, that's what I was going to ask you next. Most people ask, when do they stop taking their PPIs? Do you have them off their PPIs right away, or you kind of like titrate it down?
So yeah, I'll wean them off. I keep everybody on their PPIs for at least the first couple of weeks to help with healing, and then they should be weaned down. So every other day for a week or two, every 3 days, and then eventually they can just stop.
Yeah, I've heard from some patients they automatically, as soon as the procedure is done, they know that there's no more reflux. There's just a feeling that they have. So that's interesting. Question from Tom: you kind of talked about this. How soon can I exercise after having the procedure? So you had mentioned depending on how strenuous, right?
Yeah, so I think aerobic exercise. Usually, most people don't want to in the first week, but aerobic exercise you can. I try not to keep people from, if they want to do it, they should. Abdominal exercise, heavy lifting, or anything with the core, I say about 4 to 6 weeks.
Okay, and is it different if they have a hiatal hernia versus a combined hernia TIF procedure?
A little bit, definitely with the hernia repair. Absolutely, they shouldn't do it. But even with just a straight TIF, I think you got to let that heal, and you really want to make sure you get that serosal fusion for that long-term result.
Okay, perfect. Shane's asking, can GERD be seasonal?
I think well, sort of. I think a lot of the symptoms can be exacerbated by allergies, post-nasal drip, and those things. So I think there's a lot of overlap with that. So, and actually, and how active you are with weight gain or weight loss. So I think people can see what you're calling a seasonal type of effect.
Okay. And Anne is asking, can a TIF procedure be done after an ablation?
Yes. So if somebody's had an ablation for Barrett's, or there actually is a procedure that there's an ablation to try to prevent reflux, the strata. I have not done one after an ablation, but as long as it's well healed and everything, I don't see why.
Perfect. Andrew's asking, I've had reflux for about 3 years and I take medication. My doctor said I should just stay on my medications because surgery side effects can cause more problems. And I'm wondering what to do. I'm assuming, what are your thoughts on that?
Yeah, I hear that a lot. I think I would definitely consult with somebody. I mean, in my personal practice, coming to my office or doing telemedicine or having a conversation does not mean I'm going to try to sell you surgery. I think so. You want to have that conversation. The misnomer that anti-reflux surgery is so bad comes off the traditional operation a decade ago with the Nissen. So I think with the new procedures, the side effects are very low. So, and actually, I think the long-term side effects with a TIF is actually potentially not being one of those 85% that are off their medication. So I would definitely talk to somebody that offers it and get that information for sure.
Perfect. Oh, this one's a good one. So John's asking, especially during COVID, do you believe TIF can be done as outpatient procedure, sending someone home the same day? So I think you and I talked about that a little bit before we even started, but yeah, you can talk about that.
Yeah, I definitely think a TIF can be done and people can go home the same day. It is going to be kind of dependent on the physician doing it, whether GI or surgeon, as well as the facility. So, but yes, if they may have already been doing that. There are a lot of physicians that do that already and do an outpatient. But as I tell, I think it's very safe to do that. But it's going to depend on who you're dealing with, surgeon-wise or GI physician-wise.
Perfect. Thank you. May is asking, could my asthma trigger my GERD or make it worse?
I actually would say that's the opposite. I think the GERD is probably causing your asthma, or definitely can make it worse, because if you have underlying asthma, getting reflux and fluid into the will cause a greater kind of reactive airway issue. So if you have reflux and asthma, it'd be well worth looking at. And the one thing I didn't mention too, as far as workup goes, I apologize, is that you can do a pH study as well. So you actually can measure how much acid is coming up to try to help figure out if it's a pulmonary issue versus reflux, or actually or a combination of both.
Perfect. Yeah, thank you. I'm glad you mentioned that. Maria is asking, can this procedure help bile acid gastritis?
The procedure is causing a repair of the valve between the esophagus and the stomach. So if it's gastritis and there's bile, then this will likely not be the curative that problem. But there may be a combination of things that need to be looked at. So just an anti-reflux surgery and bile gastritis is likely not going to help that.
Okay, thank you. Belinda's asking, can you have back pain from GERD?
That would be a typical symptom, I would say. You can, so I would probably say no, but if there are other symptoms that are related, then doing a workup, but I think you'd be working up other reasons for back pain.
Sure. Okay, she's asking also, if your esophagus is inflamed from GERD, can it get narrow and cause the feeling of having a lump in your throat?
Yeah, absolutely. That's one of the atypical signs. It's called globus. That's why people try to do a throat clearing. It's actually a problem at the base of the esophagus where there is inflammation and it causes stricturing there. And then you have that constant feeling of something in the back of your throat. So yeah, reflux, it's called the Schatzki's ring, is a very common cause of that sensation and the narrowing of the esophagus.
Interesting. Okay. I didn't know that. Learn something new every time I do these TIF Talks. So, we talked about, the TIF procedure and recovery. I always hear some really interesting stories from patients and from physicians. Are there any interesting stories or patient stories that you've had that kind of stand out from after doing this procedure? I know I'm throwing you on the spot, but I didn't know if you had any particular stories that you wanted to share. For example, I was talking to a physician one time and they said that, you talked about the voice box, and a patient didn't realize that her voice, had changed through the years and had not been able to sing. And then after she had her procedure, she was back to singing like she was before. So interestingly enough, that was it. I thought that was an interesting story, but I don't know if you have any stories like that.
I have done singers that lose their voice after they use it. And that has been their one complaint about reflux, and doing a TIF has gotten them back to being able to sing. And I have not a great story, but the patient not paying attention, asked them not to, just to go on liquid diet. We pulled the lobster tail out of their throat 3 days after it. So that was
You're kidding.
the whole tail. So that's why I try to be real clear on why we're doing what we're doing and why we need them to stay on liquids.
That's a very good point. Oh my God. That's a good story. Not a great story, but a good story. A funny one, if you will. You got to have some of those funny stories every now and then. We do have a couple more questions that have come up. Dawn's asking or saying, I have acid reflux for 20 years now, and I'm getting nausea a lot in the last 11 years, and I think that's what she's saying. And they gave me Zolfran for it, but still getting nausea. Is that normal?
Yeah, I
Nausea?
think that, well, again, having reflux for that long or having nausea is not like, it's not normal. So reflux and nausea can go hand in hand. It should be worked up, but I don't think, if I saw a patient like that, I wouldn't just say, just keep taking Zofran. I mean, there should be a reason that you have nausea, and that likely can be taken care of during a proper workup. If reflux is part of it, then we can take care of that. Could be gallbladder disease or gastric disease. So I would have that worked up because, again, the PPIs, the medications, Zofran, they're all just make the symptoms better. They don't treat the problem.
Yeah, perfectly said. May is asking, is it normal to have an esophageal manometry, pH manometry before surgery?
So that is individualized between clinicians. So I don't always do it. I think if there's any question of if somebody has reflux, then a pH study is done. It's a much better study than, or at least the one I do, it's called a Bravo, where it's a capsule is placed. I place it during endoscopy. So there's nothing sticking out of your nose that you used to have to wear on your cheek for 48 hours. And so that is, I individualize that. I don't do that in everybody, as well as manometry is the same thing, especially for a TIF, where even if somebody has some dysfunction, you can still do a TIF. So it's actually one of the reasons I started doing it more. So I individualize it. So it's up to the clinician on what they think is the best thing to see if they're ruling out other issues like achalasia or or if you have this LPR, the silent reflux, the pH study can help delineate if that's really what's going to help you. So we don't want to do an anti-reflux surgery and have somebody still have symptoms. So
Right.
it's to really narrow down what that we're going to do a procedure, we're going to get good outcomes, and the patient's going to be symptom free after.
Right. And I like what you said, that it's kind of like patient specific. It's personalized to every patient, and every patient is different, right?
In my practice.
Yeah. Yeah. Wonderful. Let's see. There's a couple other questions. I think we've answered most of them. Here's one from Belinda. I've been taking Dexilent for a few years, but it is no longer working. Should I switch to a different medication?
So that's definitely a strategy for patients that are being treated medically, that one PPI doesn't work, so you can switch to another one. Dexilent is actually one of the last lines that we use. So when most people are failing Dexilent, there's not a lot to go to. So, or at least that's what I've seen with my GI colleagues here in Western New York. So, but that is a strategy to try to switch between PPIs to find the one that works.
Perfect. Thank you. Last question we're going to answer tonight. Kathleen's asking, what is the criteria used to determine if the TIF procedure is successful?
I think the biggest criteria is patient satisfaction and how they feel. So do they have symptom relief afterwards? Because most of this is driven by symptoms. And also if there's prior inflammation or esophagitis or other sequelae of the reflux, then I'll sometimes do a retest them. So I had a patient with severe esophagitis. We do an anti-reflux surgery with the TIF and scope him 3 months later, and his esophagus is completely clear. So sometimes it's just looking back, but I just kind of go with what the patients tell me. They're reflux free, symptom free, and doing well.
Wonderful. Perfect. Well, that is all the questions that we have tonight, and we've talked about everything. Is there any last comments that you'd like to make, or any advice that you'd like to give to any patients that may be watching or suffering from GERD?
Yeah, like I said, I mentioned before, I mean, if you have symptoms, you're suffering from it, been on medication for a long time, it's probably worth at least having a conversation with somebody that does anti-reflux surgery to decide if you're a candidate, if it would help you. Because again, there's still some negatives about this type of surgeries that are not valid, actually. So have that conversation, and there's definitely help out there.
Perfect. And you're in Buffalo, right?
Right.
Buffalo area-ish? Okay, so if you're in that area, you can obviously contact Dr. Eckhert and his practice. And that's through the Mercy Hospital of Buffalo, is that correct? Or okay, fantastic. And if you're not, and you're trying to find a physician or a TIF physician in your area, you're welcome to go to gerdhelp.com. There is a physician finder there, and you can put in your zip code or your state, and you'll be able to find physicians in your area that offer the TIF procedure. We can't thank you enough, Dr. Eckert, for joining us this evening. We really appreciate it, and I know that the people that are watching that ask questions really appreciate it. And then also to all of you who ask questions, thank you for joining us this evening. But Dr. Eckhert, thank you again. Have a fantastic evening. Stay safe out there. And we'll catch you next time.
Well, thanks for having me, and I hope everybody learned something.
Yep, absolutely. Thank you, everybody. Have a great evening.